Good morning. Welcome to our first YouTube video. We're really excited to be launching this channel, which is going to be dedicated to bringing you information about infertility in general. Today we're going to start with endometriosis, which many of you have asked about and want to know more information on. So we're going to start with a longer video than we typically have, but we want you to share, ask questions, add comments if you like, and make sure you subscribe because we're going to have many more videos coming in the coming months. Thanks. So what is endometriosis? Endometriosis is when ectopic glands or stroma from the endometrium find their way into another site, such as the ovaries, the tubes, the outside of the uterus, and sometimes the distant sites like the liver, the diaphragm, the brain, or even the umbilicus. And when they arrive there, they can often cause fibrosis, and that fibrosis can lead to complications, pain, infertility, bowel obstruction. What does that really mean in plain English? So it's when the tissue from the inside of the uterus, which we refer to as the endometrium, finds its way to sites where it's not supposed to be in. All of those sites that I just mentioned, including ovaries, tubes, uterus, and so on. When it lands there, it attaches to those tissue locations, and then once it's attached, it causes inflammation, and your immune system tries to attack it to get rid of it. When it tries to attack it, it frequently leads to a lot of pain and a lot of discomfort, and then also problems with bleeding, with your periods, pain with intercourse, and in addition to that, a lot of patients suffer from infertility. I want to make sure we outline some objectives, and that's important so that we all know what we're going to be talking about. So the objectives for today are going to be define endometriosis and its subtypes, review the epidemiology of endometriosis, so A, who gets it, B, what increases the risks of getting it, and C, is it genetic? 3, we're going to discuss what the symptoms are and how you figure out if you have it. 4, we're going to find out if it affects fertility. And 5, we're going to talk about treatment. So we're going to specify 3 different parts of the treatment. 1, natural therapies, which I know is of great interest to a lot of our patients and people out there. 2, medical treatments, so pharmaceutical medications that we use to treat endometriosis. And 3, surgical treatment. So there are 3 types of endometriosis, and we're going to go through each type. I'm going to show you some videos, so if you're squeamish, just be careful because we are going to be looking at some surgical videos here, okay? So the first type of endometriosis is a superficial lesion. This is just a deposit of that endometrial tissue somewhere in the surface of your pelvis. So if you look on the screen here, you'll see that there's some endometriosis where there are these little black spots right there and up at the top as well. There's a little spot at the back there. And then there's some vesicles over here as well. All of those are different types of endometriosis, and they can all cause the same symptoms. So the second type of endometriosis is the deep infiltrating type. These are the superficial lesions, but they can actually invade into some of the tissues, the bladder, the bowel, the pelvic sidewall. If you look at the screen here, you'll see an example of an endometriotic lesion here, which is invaded deeper into the pelvic sidewall. And because it's a little bit deeper and it's near some sensitive structures, we're actually going to have to remove this piece. In a non-critical area like the pelvic sidewall, this is possible if you're careful. If it's on the bowel, you may need a general surgeon to be involved, or if it's on the bladder, maybe a urologist. Third type of endometriosis is when you see a cyst of endometriosis, also referred to as an endometrioma. Endometriomas are when the endometriosis invades into the ovary, creates a tissue layer, and inside that you're actually menstruating into the inside of the cyst. When they get cut open, they frequently have blood or a chocolate colored fluid inside it, and that's why they're often referred to as chocolate cysts as well. You can see it here in the surgical video. There's an ovary right here on the right side, and inside the ovary is a cyst of endometriosis. We're starting to take it out, and you'll see the grasper go in there in a moment. It'll grab onto the cyst wall, and then you have to peel that cyst out of the ovary very delicately, making sure that you don't injure the ovary in any way. There you can see us grabbing onto it, and it starts to pull out and pull away from the ovary. You want to do this carefully so as not to damage any of the ovarian tissue. So just so we're all clear, when I've mentioned endometrium before, the lining of the uterus and the glands and the stroma, you can see it on the slide here. So this is the uterus. The lining is the part that goes on the inside. Early in the menstrual cycle, you have your menstruation. So it's quite compact and you can't really see the glands and the stroma all that well, but they are right around there. Later into the menstrual cycle, you're starting to build up your lining. That's called the proliferative phase. And so you can start to see the stroma, which is the spaces in between everything, and the glands, which are these little circular areas. When you get into the final part of the menstrual cycle, you're in the secretory phase, and you can see the glands are getting much bigger. So it's all of this tissue that's actually attaching to other parts of the body outside of the uterus, and that's what we call endometriosis. So there's 4 theories of how you get endometriosis. And I know all of you want to know, how do you get it? Is it something you're born with, or is it genetic, or are you predisposed? So the reality is we're not 100% sure. No one has ever definitively been able to distinguish which of the theories actually are the correct one or the only one. But we do have about 4 or 5 different thoughts on how this occurs. So the first theory is what's called metaplasia. And what that means is that one cell type becomes another cell type. So maybe you have a tissue layer inside your pelvis and it just suddenly kind of undergoes a transformation into an endometrial cell. The second theory is that one tissue from the uterus will travel from the uterus through either your blood or your lymphatic system and go to another location. And this is often the explanation for why you get it in strange places like the brain or the diaphragm or the umbilicus. The third theory is that you're actually just born with it. It was there right from birth and that it's going to stay there, and it just doesn't develop until after you've gone through puberty and had several cycles. Once you start getting the hormonal changes that come with your pubescent state, that's when it actually starts to develop and cause problems. And then the fourth theory is that there's surgical spread. So maybe we've actually gone in to perform surgery and it entered on the tip of one of our instruments and we moved it from one location to another. The final theory, the most common theory, is what's called retrograde menstruation. So retrograde menstruation is the belief that when you menstruate, instead of it all coming out through the cervix and then through the vagina and outwards, it actually goes back through your uterus and through your fallopian tubes into your pelvis. So if you look on the screen, we've got it marked with arrows. This is a bit of a cutaway of the uterus. And you can see that the menstruation is going out through the fallopian tube. It exits the fimbriated end over here, and now it's got access to the whole pelvis where it can attach to any part. The ovary right here, the fallopian tube itself, the back of the uterus, and the pelvic side wall all along the edges there. So the idea that the endometriosis can be transported from one site to another via the lymphatic or the blood system, hematogenous system, is one that's supported by patients that have umbilical endometriosis. And I was fortunate enough to report on this several years ago in the Journal of Minimally Invasive Gynecology. There's a review where we looked at all of the cases that had been reported to date of patients that actually show up with monthly symptoms of bleeding from their umbilicus because they actually have endometriosis at the belly button, and it'll bleed and get irritated and painful every month as women go through their period, and then it kind of heals. And we talked about the different management for that, which includes either medical therapy or surgical therapy. So rates of endometriosis in terms of its epidemiology are really difficult to determine because it really depends on what the patients are presenting with. In general, over half of the patients have no symptoms at all, so sometimes we don't even know that they actually have endometriosis. In other cases, they may be presenting with pain, they may be presenting with heavy bleeding, painful intercourse, or sometimes it's diagnosed at surgery or because they have infertility. So it's really hard to pin down. We do know that it is definitely related to age. You're very unlikely to get endometriosis prior to puberty, and it tends to settle down considerably after menopause. So if you look at the slide, we can see that at the young ages, 15 to 19, the rates are quite low, less than 1% per 1 per thousand population. But as you go through your reproductive career and you get to the 40s, you can see you're peaking where almost 18 or 19 patients per thousand are developing endometriosis, or having it found in their system at some point. So in general, we find that it's anywhere from 2% on the low end up to as high as 50%, but it does depend on the population, your genetics, your family history, your exposures, and all of the other risk factors that go along with it. So in terms of exposures or risk factors for endometriosis, there have been numerous studies. One of the best is by Shafir et al., and that's shown in this diagram. So if you look at the diagram, when you look at early in utero life, when you're still a fetus, low birth weight for the infant is a consistently increased risk. If there is prematurity, it may be associated, and we are not sure about diethylstilbestrol exposure, although we really don't see that at all anymore. It was something that happened about 40 to 50 years ago, and it's no longer ever used, so we're not seeing the outcomes of those cases any longer. What doesn't seem to be really associated is maternal or paternal smoking. That doesn't seem to cause an increased risk of endometriosis. However, it is terrible for you in pregnancy and for fertility, so please do not smoke when you're trying. The next stage of life, of course, is childhood and adolescence. And during your childhood and adolescence, there don't seem to be a lot of increased risks, but there definitely are some concerns. So earlier age at starting your menarche, so when you first get your period, may be associated with it, as well as lower body mass index. So those are the patients that are really, really thin. The other factors we're not quite sure about, so things like smoking exposure or smoking yourself, increased or decreased physical activity, obesity, those are things that are still to be determined. Finally, in adulthood, there continue to be some concerns, and I'm not going to draw your attention to all of the factors because, as you can see, there's a whole list of them. But what does seem to be important is women that have shorter cycle length tend to be at higher risk. And again, if you're very thin, you tend to have a higher risk of having endometriosis. Conversely, the women that have had more pregnancies, greater parity, they tend to have lower risks of endometriosis. So it may be protective, and that's why we definitely want to try and encourage patients to have pregnancies that are healthy and safe, not to treat endometriosis, but because overall it's beneficial for you from a health perspective. Next question we want to answer is, what symptoms do people normally get when they have endometriosis? And as I mentioned earlier, we know that almost half of the patients don't have any symptoms at all. So you could have endometriosis without knowing it. But typically we talk about something named the 3 Ds, and that stands for dysmenorrhea, which is when you have painful periods, dyspareunia, when you have painful intercourse, and deep pelvic pain, which is just, it's really sore or achy or chronically painful in any part of your pelvis, but kind of deep inside, not so much on the outside where the vulva and the labia are, but deep inside the vagina or up higher into the pelvis. There are potential other symptoms of endometriosis, and these mainly involve its impact on other organ systems. So if it is involving the bowel, you may have painful bowel movements. If it's on the bladder, you may have pain with your bladder sensation or pain when you're urinating. If it's involving other organ systems, including the diaphragm, you can have even strange things like holes in your diaphragm where your lungs collapse. And I actually had a medical student colleague of mine when I was training that had that. She had a pneumothorax, which is when you blow an air hole in your lung once a month every time she got her period. So what does this mean overall? In total, 58% of patients presented with some type of pelvic pain. And that's critical because if you have pelvic pain, we've got to at least be suspicious about the potential that you have endometriosis. It also means that you're 10 times more likely to report pain with bleeding, 2 times as likely to report urinary tract symptoms, 7 times more likely to report pain related to sexual intercourse, and 2 times as likely to report rectal bleeding or dyschezia, which is pain with your bowel movements. Overall, 13 times more likely to report that you had pelvic pain than women that don't have endometriosis. So as a reproductive endocrinology and infertility specialist, I want to make sure that I urge all of you, if you have any of those symptoms, pelvic pain, deep pelvic pain, pain with your bleeding, or pain with intercourse, make sure you ask your gynecologist or your family physician to evaluate you further to make sure you don't have endometriosis, because there are loads of options for treatment, and we want to make sure that you have access to that treatment. So The most important thing you all want to know is how does this impact my fertility? And of course, we'll talk about treatment, which is important too. So in terms of how it impacts your fertility, there are three theories. One is how it affects the pelvis and the pelvic cavity. Two is the impact on the uterus. And three is the impact on the endometrium. So we're going to go through all of those, and I'm going to point to a diagram. So as you can see in this diagram, in the pelvic cavity, there are pro-inflammatory changes that can cause problems with either sperm and egg binding, or the quality of the eggs that are being released, or even the function of the fallopian tubes. And that's related through macrophages, neutrophils. These are all immune system cells that can mediate different changes, and those changes can cause problems in the ability of the normal reproductive cycle. In terms of the uterus, there's steroid factors that can be either upregulated or downregulated, and those changes can cause problems with either the binding of the embryo to the lining of the uterus or the mobility and transport of the embryo through the fallopian tubes. And then finally, in the ovaries, you can also see that there can be significant tissue problems, especially when you have those pesky endometriomas, because those endometriomas can cause a lot of inflammation. They can cause adhesions, damage to local structures like the fallopian tubes, which are vitally necessary to getting the egg and the sperm together. And then the endometriomas can also directly damage the tissue of the ovary, causing you to have less eggs and poorer quality eggs as well. So I'm sure you're all wondering, oh my gosh, do I have endometriosis? How can I find out? And the truth is, it's fairly difficult to diagnose endometriosis. We've done studies which show that ultrasound can determine if you have the cysts of endometriomas that we mentioned earlier, called endometriomas, and they're quite reliable at predicting those. But those little spots of endometriosis we showed you earlier, they don't show up on any kind of diagnostic imaging. So ultrasound, whether it's abdominal or transvaginal, MRI, or even CT scans, can't really show you those tiny little lesions. They can show you big, deep lesions sometimes, but they won't show you the tiny little ones. In terms of pelvic examination, that's something we always start with. There are certain spots in the pelvis which can cause more tenderness or pain, in particular these ligaments that kind of hold up your cervix and your uterus, called the uterosacral ligaments. They're kind of a favorite spot for endometriosis to land. If it's really tender there or very nodular, or if we feel that there's no movement of your uterus, that kind of heightens the concern that there may be endometriosis there. But again, it's not diagnostic. The true and only way to diagnose endometriosis is to actually visualize it at the time of surgery. And when we do those surgeries, we almost always will take biopsies and send the tissue off to confirm that what we're seeing actually is endometriosis. There are some tests that have been developed, especially popular in the US. Unfortunately, none of them are any better at predicting endometriosis than any of the other tests that are available, including ultrasound and pelvic exam. They may show you a slightly increased risk, but none of them are diagnostic, so it won't tell you yes or no for sure you have endometriosis. It'll only tell you if your risk is higher than someone else's risk is. Probably the most exciting part of all of this discussion is how do we treat endometriosis? And in general, there are three approaches. There's the natural approach, which we support if it's going to work. There is the medical approach, which is when you use pharmaceutical agents, generally either a hormone therapy or an anti-hormone therapy. And then there are surgical approaches, which we showed you some of earlier, including either burning the endometriosis with a variety of techniques, removing the endometriosis, or treating severe endometriosis, including removal of cysts and having to remove other areas of the pelvis that are affected by the endometriosis, such as the bowel or the bladder. So I'm going to break down each of these for you into individual detailed explanations, and we'll start with the natural therapy. So in terms of natural therapy, there is a lot of information out on the internet, and there's a lot of misinformation as well. I think it's really important that everyone recognize that although there are a lot of suggestions that treatments work, there's actually no evidence that any of the endometriosis related treatments actually help fertility patients. Specifically, there have been websites agents that have proposed many different treatments, and I want to review a few of those just to kind of go over them and give you an idea of where things stand. So starting with acupuncture, acupuncture may work for infertility patients, but we really don't know. There have been 6 randomized controlled trials. 3 of the randomized controlled trials showed no benefit, 2 showed a slight benefit, and in 1 trial, interestingly, the placebo, where they used a sham needle, which wasn't actually sharp or going into the patient, had a bigger benefit than the actual acupuncture did. So we really don't know. Experts think that it's actually stress related, and that if you reduce your stress with the acupuncture, it's beneficial, and then if you are getting more stress with the acupuncture, you should probably avoid it. Next, people have looked at diets. So certainly there's some suggestion that Mediterranean diets are beneficial for fertility patients, and there's actually some studies that have demonstrated that diets rich in sort of olive oil, natural green vegetables, fish, and omega-3 fatty acids have actually been somewhat beneficial specifically for for endometriosis reduction, but they actually have not been shown to improve fertility in the endometriosis population. So it may be helpful for IVF patients in general, but we don't have any specific data on endometriosis. Next, people have also looked at supplementation. One of the supplements that's purported to be really beneficial is something called NAC, N-A-C, and NAC stands for N-acetyl-L-cysteine. So it's a supplement you can get at most health food stores or pharmacies, and there is some evidence that this reduces inflammation, can alter the growth of endometriosis, reduce the development of new blood vessels, which is crucial for growing endometriotic lesions, but there is absolutely no evidence, again, that this actually helps infertility patients with endometriosis. Many people have also looked at the impact of dairy. Certainly from the naturopathic perspective, naturopaths will often tell you that dairy proteins can cause a lot of inflammation, and similar to endometriosis, that inflammation can have a negative effect. While this may be true, the reality is that the Nurses' Health Study, a very large study done back in the 80s, demonstrated that actually women who had higher dairy intake with endometriosis had better fertility outcomes. So again, the jury's out on this one, and we certainly don't recommend to anybody currently that they stop their dairy intake. Lastly, some people have looked at turmeric. So turmeric has a component in it called curcumin, and that agent actually is the active agent, which a lot of people are talking about in terms of its anti-inflammatory effects. Some people talk about it being used for anti-cancer fighting agent properties and so on. So while there is again some evidence that this can help with inflammatory lesions like endometriosis, numerous studies have actually not been able to show a significant benefit for fertility patients. And I'll just read you a quote. So the quote says, "The results of related in vitro and animal studies have shown that treatment with curcumin reduces inflammation through suppression of inflammatory cytokines expression. It also can inhibit invasion, attachment, and angiogenesis of endometrial lesions. Moreover, curcumin inhibits cell proliferation and causes cell cycle arrest and apoptosis." And that's where you're actually programming the cells to die, which is good for endometriotic cells. Thus, it may have potential as a dietary and pharmacological agent for the prevention and treatment of endometriosis. Sounds great so far, right? But here's the catch. The last line is really critical. They say, however, according to the limited studies in this field and inconsistent results of clinical trials on the effects of curcumin on some other diseases, further studies, especially clinical trials, are suggested to investigate the effect of curcumin on endometriosis. Lastly, there's some impact from zinc, and people have used zinc therapy as well as a vitamin or a supplement, but the reality again is that we have absolutely no human studies showing that supplementation with zinc actually improves your chances when you have a history of endometriosis. Where does all of this leave us? I don't think any of these agents are particularly harmful to you, and if you want to try them, by all means, I think it's a reasonable thing to try, but there's actually no evidence evidence that any of them help. And certainly we don't recommend that you put all of your faith or all your stock in those agents, because there are better ways to help you, especially when you come to see a fertility specialist. We have tried and proven methods that can actually assist you. One final note about the NAC therapy I mentioned earlier. There is one study that was actually touted in a website that I looked at talking about natural therapies for endometriosis. And that study evaluated the impact of the NAC on endometriomas, which are those cysts of endometriosis we mentioned earlier. So while they say that there is a beneficial effect, and they were accurate, the problem was it only shrank them by 1.5 millimeters. 1.5 millimeters, when you have one of those big cysts I showed you earlier, is absolutely meaningless. More importantly, in that study, there was no benefit on pregnancy outcomes. So again, you got to be really careful when you read what's online. They often may support a suggestion of an effect, but when you look into it a little further, or you go to the source data, you find out it's not really all it's cracked up to be. So just be cautious when you're reading things online, and if you have questions, by all means ask us. That's what we're here for. So there aren't really any natural support systems for us that we know of to help with infertility patients who have endometriosis. In fact, anything we try and use, generally speaking, is going to have some impact on your hormonal balance, or is going to require some kind of treatment or therapy with either insemination or ovulation induction or IVF. In particular, there are numerous therapies that are available for patients who have pain with endometriosis, but all of them are hormonally mediated. Things like birth control pills, desogestrel, progesterones, use of other medications including gonadotropin releasing hormone agonists, and now we have antagonists as well. All of these are available, and all of them can influence your endometriosis anywhere from slightly to quite significantly, but all of them act as birth control. You can't get pregnant on any of those medications. Certainly there's some support for using some of them for several months before you actually try to conceive, but you can't try and conceive while you're on the medications, and that's really important to note. So if your doctor offers you therapy with any kind of medication to try and shut down your endometriosis, it often will work for closing down the endo and helping to suppress the pain, the heavy bleeds, the discomfort with intercourse, but it's not actually going to help you get pregnant. In fact, it's most likely going to prevent it during that time. So for those of you who are wondering what you do when you really don't want to use hormone therapy and you want to try and stay as natural as possible, your best bet's actually to use surgery. Surgery has been proven to be beneficial in cases of endometriosis. In particular, if you have mild to moderate endometriosis, laparoscopic surgery has been proven to almost double your success rates. There was a Canadian study done as a randomized controlled trial, which is our highest level of scientific evidence. And in that study, they were able to demonstrate almost doubling of the success rates when patients were treated for endometriosis through the laparoscopic surgery. And in case you don't know what laparoscopic surgery is, it's when we make those tiny little holes on your belly and we can go in and very gently do the surgery. Usually you're home the same day, and it's generally quite safe if you're having the surgery done in a suitable facility and by a qualified surgeon. If you have endometriomas, those cysts of endometriosis, it is a lot more complicated, and I'm going to talk about that in a little bit. But essentially you have to be very careful because it can have significant impacts on how well your ovaries work after the surgery is done. If you're moving outside of using surgery and you do want some assistance from a reproductive endocrinology and infertility specialist, we do have a variety of options available to us, and it's important I go through the details with you. So number one, we can always help you make more eggs. Why would we do that? Because more eggs means more targets for the sperm and a higher chance of getting you pregnant. It's fairly simple. There are oral medications and injectable medications which can help you produce more eggs. And we're aiming for maybe 2 or 3 eggs so that we're improving your chances of success without increasing your chances of having octomom status at the end of it all. The only issue is we don't want to do it too many times, and we don't want to get your estrogen levels too high because estrogen fuels the endometriosis and it can worsen the significance of your endometriosis if you have fairly significant endometriosis already. So when we do this, we want to try and do it a minimum number of times, and we want to keep your estrogen levels fairly controlled. That means a lot of monitoring and a lot of care and attention to detail. But certainly that can improve the success rates. If you want to be a little bit more aggressive, we can add in insemination. And we can do insemination with just your natural egg production, or with eggs we help you make by giving you pills, or with eggs that we've helped you make by giving you the injectable medications. All three of those will improve your chances, but because endometriosis in general cuts your chances down about half, and those techniques generally don't have very robust success rates, again, they need to be used judiciously. You don't want to be doing it over and over again. It has to be a reasonable number of tries, and most fertility specialists will limit it to about 3 tries before they try something more aggressive. The final step is to use in vitro fertilization. In vitro fertilization is a process where we actually try and make you make as many eggs as we can within limits. We go in and we harvest those eggs in what typically is a fairly painless procedure. We extract the eggs, we cherry pick individual very good quality sperm, and we inject each of those sperm into the egg, or some people will favor just using a natural approach where they mix the sperm and the eggs together overnight and hope that they fertilize. Once that process is complete, you're hoping that you've developed embryos. You then grow the embryos for a certain number of days, usually 5, and then we take those embryos and they get transferred back into the uterus. Now, under any normal circumstances, many programs used to take those embryos right after day 5 and transfer them in fresh. And the problem with that is that should absolutely never be done if you have endometriosis. You're probably all saying, why? I want my embryos in fresh. I don't want them frozen. The problem is we just drove up your estrogen levels much, much higher than they normally are. And when you've driven up those estrogen levels to a very high number, they're really stimulating the endometriosis. That's got your immune system overactivated, all of the natural killer cells, the macrophages, the cytokines, all of the components of your immune system, which contribute to decreased success with infertility, are maximally engaged and maximally elevated. So what we want to do is actually freeze all your embryos, hang on to them, and then give you medication to try and suppress the endometriosis for at least 2 to 6 months, and then bring you back and use those frozen embryos to transfer. And there are numerous studies that have shown that that actually increases your success rate.